Okay, welcome everyone. And this is the Lymphedema Treatment Act. We're going to go over the LTA draft rules that recently came out. I thank everyone for being here this evening. We'll just have a quick agenda for tonight. We're going to introduce ourselves, do a quick LTA recap. That is partly what we did last time, but sometimes it's good to have a refresher. We're going to go over the organizations that have participated in getting this draft to where it currently is. And then we're going to go over the draft rule details. And then, of course, we have the slide where you can contact us. So a bit of the housekeeping, as I already mentioned, we are recording this. Myself and the members of our organization who are helping tonight are the only ones that have their videos on. We are in a listen-only mode. So if you have questions, please submit it to the Q&A and we will get to those. We are trying to keep this discussion to what the draft rules that were just released over the weekend. If you have other questions, you can certainly email us at info@lymphedema-treatmentact.org, and that'll be at the end of the presentation. So next, I'm going to go ahead and do introductions. I'm Sarah Bramblett. I'm the board chair for Lymphedema Advocacy Group. I am a patient who has both lipedema and lymphedema. I am also on Social Security disability insurance, so I'm a Medicare beneficiary. Next, Heather, would you like to introduce yourself?
Hi, I'm Heather Ferguson. I'm the founder and executive director of the Lymphedema Advocacy Group. I have a 16-year-old son with lymphedema, and I'm going to be monitoring the Q&A tonight. So I'll be answering some of your questions there, and I may select some questions to be answered live by Sarah or myself at the end if it's something that I think everyone would want to hear the answer to.
Jenny?
Good evening. My name is Jenny Stewart. I'm from Colorado. I have congenital lymphedema in my right leg. That's been evident since birth. And I've been a proud participant of the LTA, and I'm so glad to be here with you all tonight.
And Francie.
Hi, I'm Francie Schwab. I am a Lymphedema Advocacy Group board member, but also a patient. My lymphedema is secondary to breast cancer for about 15 years, and I've been privileged to work with these amazing people. And it has a positive impact on me, both physically and mentally. Yeah. As a Medicare patient, I will also be fortunate to have my compression garments covered that are so critical to my quality of life.
Thank you. So just again, recap what the Lymphedema Treatment Act was passed in December of 2022. It was passed as part of a larger package. Medicare will now cover medically prescribed compression garments. That coverage begins January 1st, 2024. The bill does state it will cover standard fit and custom-made compression, and for all patients with a diagnosis of lymphedema. If you haven't already, we do have a list of about, I think, 40 Q&A, frequently asked questions that we compiled since January, and we've been adding to it. I think most of it was added in January and February, but we have kept it updated. I share this information because the bill itself was very simple. I just want to take you through what the implementation process looks like. This is kind of a new slide Heather recommended just to give an idea of what we discussed tonight. So the Lymphedema Treatment Act was the bill that was passed, and we're in the middle where we're going to just now discuss what the additional details of the bill, of the rule and the coverage will be. This still isn't the final step of the implementation process. There will be some other things that will be determined by either national coverage determination, a local coverage determination, or the MACs, which is like the Medicare, the different areas of the country that Medicare have, they have different coverage areas. So, and we say that because even with what is currently been released, it might not answer all your questions. So we wanted, and I'll speak throughout when we're speaking tonight, we might mention that this might be determined by an NCD or an LCD. So we just wanted to give you an idea of how that follows. But the good thing is the Lymphedema Treatment Act as you see, was very simple bill language. And we want to keep that simple because, again, it took us 12 years, almost 13 years to get this passed. So any changes to this would take another act of Congress. So we wanted to have it be simple and give CMS the ability to make those rules and those details, because it's easier for CMS to make changes than it is for Congress to make changes. And for those of you who might not know, CMS is the Centers for Medicare and Medicaid Services. So I'll be mentioning a lot. But so what I mentioned in that previous slide about what the bill did, very simple bill, established a benefit category for compression garments and provides the date that coverage starts, and cuts custom and standard fit, and for patients with lymphedema. This does not cover anything to do with pumps or surgery or manual lymphatic drainage. Those parts of therapy are already covered under a benefit category. Pumps are covered as durable medical equipment. Surgeries are covered under your regular doctors and surgical services, and MLD is covered under occupational or physical therapy under Medicare. So the reason we needed the Lymphedema Treatment Act, because compression garments did not fit under any current benefit category. And so they created a new benefit category specifically for compression garments. We wanted to just list the organizations that have participated in the draft process, and this process started in January. Our organization, the Lymphedema Advocacy Group, held listening sessions with CMS, as well as all the other organizations listed here. Those listening sessions were basically a time when the organizations could speak directly to the group from CMS who are working on the details of the coverage. CMS basically took in information due to their requirements under the law. They weren't allowed to share much information about the process, but they were very open to hearing from all different organizations and stakeholders as to what we wanted to see in the coverage details. And I just wanted to point out, because I know here, so U.S. Compression Alliance is an organization made up of all the manufacturers based in the United States and some other organizations. So, sorry, I won't list them all, but so the manufacturers of your compression garments who were part of that conversation with CMS. And if you are a member of any of these organizations, I know there might be some occupational therapists or physical therapists who are currently on the call. You might have received information from your organization, also soliciting feedback on the draft rule, or you might be receiving that soon. So again, the proposed rule, the lymphedema coverage, is part of a larger rule called the home health rule. Just as we were part of a larger package when we passed Congress, we're part of a larger rule. So there's a lot of information. I think over 300 pages, the draft rule is, and the coverage for the Lymphedema Treatment Act is about 20 pages. And we do have the links to both of those available. They were also part, if you received the newsletter, they were also part of the newsletter. And again, we pulled out, and so I just have it highlighted here so you can see. I forget exactly what page it was on, but where it starts, and it's about 20 pages worth of details for the Lymphedema Treatment Act. So the coverage highlights, as we anticipated, there's information about allowable quantities and replacement frequencies and exceptions, information about custom-made supplies and compression garments, and the vendors and reimbursement rates. And something I want to reiterate, down in the bottom corner, I put this here. This is a draft. This is not the final rule. So there's certainly things that people will agree with, and there's certainly things that people think might need changed. And what we are here this evening to do is go over what the details are. There's certainly a chance for things to change before the final rule is released at the end of this year, or towards the end of this year. So the allowable quantities and replacement frequencies and exceptions. So in the rule, CMS proposes covering 2 daytime garments every 6 months, and 1 nighttime garment each year per affected body part. So, and it's good that it says per affected body parts, because then that covers patients who have, bilateral lymphedema, or if they have both lower and upper extremity lymphedema. And we specifically wanted to make sure it said body parts, because we wanted to make sure trunk and genital and abdomen and head and neck are all part of that. We didn't want them to use just the word limb or extremity, because sometimes then that limits just to the arms and the legs, and it doesn't provide that coverage language for the other areas of the body that we all know lymphedema can affect. Both day and nighttime garments can be replaced sooner if lost, stolen, irreparably damaged, or if needed on the basis that the beneficiary's medical or physical condition changes. This was also something that we were hoping was included, and it has been. And then the last thing is compression bandaging systems will be covered without limit during the intensive reduction phase of treatment. So that is like the short stretch bandages that patients typically use when they first are initially diagnosed and get that first reduction phase. So when it comes to custom-made supplies and custom compression garments, covered supplies will include standard fit and custom fitted garments, fitted gradient compression garments and gradient compression wraps with adjustable straps, compression bandaging systems, and other items to be determined by lymphedema compression treatment items. Additional items will include the accessories such as zippers. Oops. Let me go back. Sorry. As the zippers and the liners worn under the garments or wraps, adjustable straps, padding or fillers that are necessary for the effective use of a gradient compression garment or wrap, and with adjustable straps. They also did in the language mention aids to put on the compression. So the vendor and reimbursement rates, CMS does propose that the 2024 reimbursement rates will be determined based on existing reimbursement amounts used by Medicaid and TRICARE, and when necessary, average online retail pricing. It's a little wordy. For those who are interested, you can read it in the exact language, but they're proposing to look at those rates, and a lot of it is 100. The rate, like for Medicaid, when there's areas that there has been Medicaid reimbursement, they look at that rate plus 20% as a reimbursement rate. And they are proposing to add new and additional codes that will be created to facilitate the reimbursement, including codes specific to the non-limb areas of the body, head, neck, genitals, torso, and to ensure that supplies needed to treat these areas of the body are included in coverage. This is an area that the Compression Alliance is working on. That's more their specialty area, but we are very pleased again that they are including all those additional areas of the body and making sure there's more specific codes available for these items when it comes to reimbursement. And again, this is only a draft, it's not the final. This is just initially what they have put out. And so again, the public comment period will be the opportunity for everyone, all stakeholders, to provide feedback on this proposed rule. And the comments can be supportive and are critical of any part of the rule. So you can have a comment about every aspect we've mentioned. You could have a comment about just one specific area that you want to make a comment on. All comments will be read by CMS. And as we mentioned in our previous webinar, the quality is more important than the quantity, and only one comment per individual entity may be submitted. When should you submit a public comment? Our webinar next week. So tonight we just wanted to go over the details. Next week we're hosting another webinar, and the topic will be how to compose and what you should include in that public comment. So we will notify everyone So we'll go over the webinar and the information in the webinar next week. And then when we're ready to have you submit, we'll have an action alert. We will have a streamlined submission process that you'll be able to use. And you will need to write your own personalized comment. And we are willing to help you compose that if you do need assistance. There's no rush. It's better to take your time to compose an effective personalized comment than to submit it quickly. And a comment submitted on day 60 will count as much as a comment submitted on day 1. I know for myself and Heather and others who, this proposed rule came out, I said before the weekend, and it's a lot to understand and a lot to process. But we know people were very anxious to see what CMS was going to come out with. I'm pleased with the initial, it really shows that they listened to us. There's certainly things that can be improved on, but I think it really showed that they listened and understood the need of lymphedema patients. So, and again, we'll help compose. If you want to make sure you are registered to our newsletter so that you know when the action alert is ready. I'll go ahead, Heather or Jenny, if there's questions that need to be answered.
Most of them I have already answered in the Q&A, but this one I have not gotten to yet, and I would imagine there's others who are curious about this as well. The question is, does the diagnosis for lymphedema have to be documented by a physician, or can it be a primary diagnosis by a PT or OT who is treating the patient?
So I believe that is, let me back up because I think that mentions, it has to be, I think this might vary by state. And that, let me go back to, no. So it has to be prescribed by a physician or a physician assistant, nurse practitioner, or clinical nurse specialist, as those terms are defined in section 1861 to the extent authorized under state law. So yeah, they're going to have to be prescribed by a physician or someone who can make that diagnosis, but I know the laws do change, or I'm sorry, they do vary, and that some levels of physical and occupational therapists now are doctorate levels, so they might have that ability, but I don't have that answer. That might be something we need to ask and get more clarification on.
I'll just answer this question live as well. Someone's asking about a copy of the slides. We were not intending to share the slides, but we will be sharing a recorded copy, perhaps the one that we are doing right now, which we are recording, or we may just do a separate recording of the same content, but we will definitely be providing a recording.
There's a good question that I've started to create an answer for, but I think it might be good to answer live. So the question was, I plan to submit my comments. Can other therapists in my practice also submit comments? So what's the answer to that?
So yeah, so it's public comment. So that means public, anyone can. I know for an example, the lymphedema advocacy group, so organizations and individuals can submit comments. So as for our group, lymphedema advocacy group is going to submit comments as an organization. And I know myself as a patient and private citizen, I'm going to submit comments as an individual. So yes, the practice can and individuals can. So you can ask your coworkers, you can ask your patients. There's no limit to the numbers, but we want to make sure, as we discussed during our last sessions, we want these to be unique comments. CMS, if everyone's just saying the same thing, they'll realize that it's a form letter. We're not giving out a form letter. We're not putting out a template, because it's better if someone shares their own rationale for why they want to see a change or why they support something that's there. We don't want to just talk about changes. We want to make sure we support what's there. If there's something there we want to keep, but certainly it's available and open to anyone who wants to submit.
We have a couple of questions about pricing and reimbursement rates. One person is pointing out that if it's based on Medicaid pricing as it currently stands, then the reimbursement rates will vary state by state. Yes, we also recognize that that was likely to result in price differences. And so that is something we plan to address in our comments, and I would encourage others who are concerned about that to also address that in their comments as well. It's certainly an imperfect way of doing it. I don't know that there is a perfect way, unfortunately, but if you have suggestions on how it could be calculated in a better and more equitable manner, then I think that is important information to include in your comments. And likewise, there is another person saying if it's based on Medicaid reimbursement rates, basically that the reimbursement rate would be extremely low. And yes, that is also a concern as well. And again, something important for you to include in your comments. And I think Sarah wants to add more to that.
Yeah, you can tell so they will range state by state. The way I read it in the proposed rule is, and this will probably be something as the max. So again, the max are the different areas of the country. So different states are different max for coverage. So what I understand is if there's Medicaid coverage that exists in that MAC, it's going to be the average. So if there's several states that have it, they will look at the average reimbursement rate of those states. So it's not going to be it'll be based on state, but not as state to state specific. And they are looking also at again, if you read it, if this is something you are interested in, you understand better, because I didn't want to put all the details out here for everyone who might, it gets deep. But they talk about several ways, not only looking at the Medicaid, but what TRICARE is available and online retail prices. And they have different scenarios of if this information exists, this is what they would use. If this information doesn't exist, or this information exists, this is what they'll use. But as Heather mentioned, this would be certainly something to discuss in your public comment if you have feedback to give and rationales and additional information to support your stance on it.
I think there's an interesting question that maybe you can try to answer live, or at least admit that we'll maybe look into it. Mm-hmm. But the question is measurement a billable service? If so, will it be covered by this law?
So that is actually something that is mentioned. If you look at the LTA specifics, it is an area that they don't have sorted out yet, and they are looking for comments. I assume this person is either a fitter or PT or OT. And so I think those organizations will be taking feedback in relations to that. But again, that is something that is discussed in more details in the proposed rule.
Another interesting question, and it might relate to something that we just talked about a little bit earlier in the prep. Do the current codes already specify laterally right versus left and count as two different parts?
So I'm looking, is that, so are we speaking of diagnosis? So to me, a right and a left would be a diagnosis code, and these are only, sorry, this isn't what they're trying to, so these aren't diagnosis codes that are being proposed. These are what would be considered treatment or product codes.
But a product, I mean, there's a right hand and a left hand. So how do we differentiate that? Or does that matter for?
I don't think that will, I don't see it differentiated.
Yeah,
Heather?
And that was one of what we considered the most important victories in this draft rule, is that there were no total limits set on the number of garments a patient could get, because that would create a situation where someone with fewer body parts affected who needs fewer garments at one time it might be enough for that person, but it would not be enough for a person who is affected in many different areas of the body. So there is no limitation on the number of garments each person can get. They're looking at them as sets of garments. So whether you need one garment to wear at a time, or 3 garments, or 5 garments, that is one set, and you are eligible for 2 sets every 6 months. So I think that there is not the concern then of if it's right and left, it counts as 2 pieces. That's not a concern.
Thank you.
I see one, will CMS specifically, yes, the new codes do state the different levels of compression, and that's part of it. So if you look at the proposed rule, everything's not finalized, but they do state that the new details that they're proposing and the different levels of compressions are listed out there.
So on this, Sarah, I just want to see if you can comment on it further. When I looked at that table, I saw like, 30 to 40 or 40 to 50. Some patients get 50 plus, but that's not listed on the table. So is that an example of something that someone should comment on to help ensure something like that gets covered?
Yeah, because I don't think the table is the complete, because some of them just have like ... So certainly if someone utilizes that, they can state that they want to make sure it's a full list. And again, the Compression Alliance is also working closely with the coding situation and making sure that there's proper or enough codes in there to cover what patients need.
And another question that others may be wondering about as well is, how will nighttime versus daytime be determined? Is it based on how they are used or how they are sold? And that's an excellent question, because there are many products that are able to be used for either one or both. So our interpretation is that it's based on how they are used. Sarah, do you want to add to that? How that individual patient would use it, not how everyone uses it necessarily.
Well, they are descriptive in how they describe both of them in the proposed rule, and then how they're made. I mean, because technically I might, that's something we might need clarification on, but they described, how they're, what stretch and that type of, and even the manufacturers had described the longevity of them. So that is actually part of the language in the rule, is the description of what they consider daytime versus a description of what they consider the nighttime. Like for example, myself, because I usually use the inactive versus active. So because I, don't have a daytime job where I'm out and about a lot, like I wear my Jobst Alvarex when I'm actually out doing errands and tasks, but when I'm home and I'm usually in my bed with my legs elevated during the day, I would wear, wraps or the tributes. So, and the tribute would be considered a nighttime garment, even though I have mine on during the day. So that might be an area that needs to.
Yes, I have noted that question as something that we need to look into further then.
Yes.
This one might be a good one to speak to just generally. The question is, it's difficult for me as a patient to comment on the proposed coverage for pricing and reimbursement rates, as I don't know if they are sufficient. How do you think that the process will help regulate some of that?
Well, so I know as a patient, and I don't have I have a better understanding than most, but the stance can just be that you want it to be sufficient enough that there's vendors available in your area. And of course, we can get into more of this next week's webinar, or people can email us directly. But I mean, I know I've been a patient for, well, I've been a diagnosed patient for 20 years. So I know what typically they pay for. So, and I wear custom. So I know if I saw a reimbursement rate that said they'll reimburse $100 for a custom leg garment, I'd be like, no, that's not enough. I don't think we've actually seen anything. Most of what I think we saw was for standard fit in their proposed rule. So I would just want to make sure that I say, reimbursement has to be adequate enough that there are vendors who will accept Medicare for these products and supply them to us. And I think someone just mentioned, no, we don't have any details on what the custom reimbursements will be. I do want to touch on, well, I'll touch on this because it has been brought up before. And let me scroll up. Someone mentioned, Daniel mentioned that Medicare used to cover garments maybe in the 90s or something. I wasn't a Medicare patient at that time. It's something we've heard. This is it. What we found as we were trying to get the lymphedema advocacy or the Lymphedema Treatment Act passed was several years ago, they tightened up the definition of durable medical equipment. I know when I had private insurance, my compression garments were covered under my durable medical equipment benefits. Several years ago, Medicare tightened up the definition of what durable medical equipment was, and they defined durable as had to last 2 or 3 years. And so compression garments don't meet that definition. And so that's why, when this bill was started in 2010, we were told that they don't fit under a current benefit category. So it's possible they were, covered that many years ago. And I'd see in their comments that they based on invoiced amount. We certainly wouldn't want them to base that on any reimbursement rates or amounts of in the 90s. That is certainly information we could share with them. And maybe if they look at, changes in pricing and otherwise, but that is something that I know what we discussed, just throughout the years of advocating for the passage of this bill was kind of like when people say why they aren't covered and how did this happen and things like that. That was the explanation and we found where the definition of durable was tightened up.
I think another interesting question, Sarah, it's just to emphasize the scope of what this bill covers. But the question is, can you talk about billing of bandaging systems and what is included or what we can personalize for a bandaging kit? Because that's not really part of the scope of this bill, is that correct?
No, bandages are mentioned, bandaging supplies. There's actually, if you look into the rule, there's quite a bit of discussion about that, and it's an area that CMS has requested additional information regarding.
Okay, thank you. I didn't realize bandaging systems would end up being part of this, so thanks for that question.
No, that is mentioned. Yes, so that was mentioned under, and actually currently the compression bandaging, they don't have a limit set for it, but they only mention it during the intensive initial phase. And then of course the other elements to that would be, the liners and things like that. When you think about when you're doing wrapping, you have liners or padding and different pieces like that. So that's going to be covered under this, the additional like accessories and items.
And weren't we both also talking about, as a comment, possibly saying that, we feel strongly that it should be maybe covered also under the maintenance fee phase of lymphedema to have the bandaging supplies covered under the maintenance
it's
as
something
well as
that
the intensive.
it's something we want to
medicine.
point out to CMS that there's some patients who use bandaging as part of their maintenance phase versus just the intensive reduction phase.
Right.
Is there language about who can charge for garments? I've requested to get additional information. We were told by CMS that you need to be registered as a Medicare supplier. That, from what I've been told, that doesn't necessarily mean a DME supplier, that as a Medicare provider. So if your clinic or physician already is a Medicare provider for your physician services and your professional services, there's a way just to become a supplier under that. But we're requesting additional information that we can share so that you know exactly what you would need to do. When I looked it up online, it seems like there's different information for someone who's already a provider to add supplier to their services versus someone who wants to be like a DME standalone provider. I'm seeing some comments regarding like the quantities and available. Again, this is the draft. So any of those types of comments or feedback that you have will be what you need to put into your public comment. This is our opportunity to make that plea to CMS to make those changes. And we're going to discuss that process and how to put those into effective public comments on next week's webinar.
I'm trying to capture these questions so that we have them if we can't answer them tonight.
Molly, I believe they are working on that. I am not completely for sure. I don't want to speak for the Compression Alliance, but I believe they are working on getting that information as well as some of the coding information to CMS.
So folks are asking for a copy of the Q&A, and I know on our LTA website, we often add, frequently asked questions. Is the plan to update our FAQs for this?
I don't want to commit to this at this time because we have a lot going on, and some of these questions are we'll get back to them, or the answer is in reading, and interpreting the document. And I know other organizations, just like I saw another question about the fitting or the measuring, that's not, we don't have an answer. I believe, and as I stated, APTA, AOTA will put out comments or soliciting feedback regarding all of the rules. And that's something that really affects that their organizations. There's a question about Medicare Advantage. At this point in time, I do not know how those tools will affect Medicare Advantage. They do have to cover what Medicare covers, but sometimes they are allowed to cover it differently. So I'm not sure how this will, how they will take covering these items. And with the quick turnaround time, I don't know at what point that might be a question if they have to be ready with coverage January 1st, probably also. But they can, just like with any other service or product, they have to supply it, but sometimes their coverage can be different.
I'm not sure I fully understand this question, but if I'm interpreting it right, it seems like two separate questions. So it says, under the current guidelines, a provider cannot self-refer. How does a provider request to be a DME supplier? So, and it references the Sunshine Act. Are you familiar with that, Sarah?
It rings a bell from my education, but I think usually if they are an owner of both, this would be, I think the example I'm thinking of is like, my primary care physician also administrates vaccines under Medicare Part D sometimes, but in their office. And so they can bill for both, or like a pharmacy usually does Part D, but can also do Part B. And since all this would be under Part B, if it's a clinic that's already doing physical therapy, and then they would be able to be the supplier and supply those and bill. And I don't know, to me, I would think there's other aspects. I don't know, whenever a therapist fits for or provides a brace or something like that, sometimes they provide those right in the clinic. So again, this is kind of outside of our scope of the organization. We're just trying to give an overview of what the proposed rule at CMS is currently released.
Let's see.
Someone's asking about Kara is mentioning, again, it says submitted for diagnosis, but in the proposed codes for the products, they do have them from like knee to waist. So that would cover, if it's up to the waist, that would cover the abdomen or the buttocks. That's my understanding of that. If it's something that's up to the waist. But certainly, again, that can be submitted as a comment that you want to make sure that those are included. So when I wear capri, so I was looking to make sure thigh, abdomen, everything was covered in that list of their recommended additions. Heather, do you see anything else?
Sorry, I'm madly typing as you're talking.
I know, thank
Let
you.
me see.
It seems like the other questions are more complex and might need.
There's been a couple of patients asking for guidance on how they can submit comments related to reimbursement. So I'm generalizing that. But this is, again, what we're going to focus on next week's webinar is really how to prepare your comments and what you should choose to focus on. So our general advice is you should not feel that you need to comment on every single part of the rule, especially if it's not your area of expertise. Talk about the things that you know, the things that you have personal experience with. Expertise doesn't necessarily mean I have a medical degree. You have expertise just because you're a patient and you live with this every day. And sometimes that is more powerful than a fancy title. So talk about the things that you know from personal experience, and don't try to weigh in on every single thing if you don't have the right information to add value to that part of the conversation. I think your personal comments will be the most effective if you focus on what you know and trust someone else who is the expert, say, in billing and reimbursement to address those portions of the rule. So again, there is no obligation to comment on every single part of the rule. You can pick even just one thing, and that is valuable.
I've seen some others about the reimbursement rates, and they're from people who are part of the distribution and vendors. It's completely understandable. My recommendation is that list that we shared, we're the grassroots organization that helped get this bill passed. We're more made up of, and we have a very diverse board, patients, caregivers. We do have some therapists, we do have some industry on our board, but that's not our area of expertise. So I put this back up there. If you are a member or more in line with the expertise of any of these organizations, I would suggest maybe reaching out to them for some clarification on this or for more assistance on this, because I don't want to, I can just say, I don't know. As a patient, as an organization, we want reimbursement to be enough that vendors provide the product. And that's as much as, I don't know any of the details of how that comes about or how that works even with other private insurance or other entities. I know there's a system that exists, but my goal is just to be able to make sure vendors are reimbursed at a reasonable rate so that they provide these products for us. I've lived in a very rural area of Ohio. I now live in Miami, Florida, and I've had equally difficult times finding people who can provide custom garments that took insurance when I had private insurance. So we certainly want the availability to be for everyone. We wanted to make sure this bill gets passed, and it's not just passed on paper, that it's actually implemented so that patients do actually have the access to these compression garments. And that includes that suppliers get reimbursed at a reasonable rate.
And I apologize, I cannot get my video to come back on, but this is Heather Ferguson talking. I'm just the butterfly on your screen. I also wanted to add, and I don't know if Sarah mentioned this earlier during the presentation, it's not only important to comment on the things that you aren't happy with in the rule, it's also important to comment on the things you are happy with, because we certainly don't want them to change something that we liked because nobody spoke up and said, this is good, keep this how it is. So I think that it's important that we don't overlook that. If there's something good, like for example, I already highlighted the fact that they're looking at the garments as sets of garments, not individual items, to make sure that those with more extensive needs still have access to everything that they need. That's something important that we should all be saying, you got this right. I agree with this part of the rule, but in this other area, I think you could improve it by changing X, Y, Z. So don't forget to tell them what you like as well.
Heather, do you have the email, information? Someone's asking about competitive bidding, and that is mentioned in the rule. But as like with other things, it's kind of confusing, especially if you're not in the if you're not in this as your day-to-day thing. So
all we know for certain is that starting in 2024, the items, nothing will be competitively bid. They will use the methods that Sarah already described in the draft of looking at existing reimbursement rates under Medicare, TRICARE, and average online retail pricing. There is language that allows them the option to, at some point in the future, put any or all of these items through competitive bidding. However, there is no set date for that, so it may or may not happen. And for those of you familiar with competitive bidding, the whole system of competitive bidding is a little bit on the rocks, and they're always trying to kind of make changes to it as a whole. So who knows how it may change before they would even get to trying to competitively bid these products. So I think we have more immediate things to be concerned with. All we know is that it could happen at some point, that they would want to put everything through competitive bidding to price them that way. I'm sorry, did that cover everything you had in mind, Sarah, or did I leave anything out?
Yes, I think the most important thing is it's not going to be happening in 2024.
No. I think
And
there
we,
are a few remaining comments from DME providers or people who are concerned about their suppliers staying in the business. Again, if you are a member of industry, you may want to reach out to the U.S. Compression Alliance or your other professional organizations, if you belong to any, to talk to them about your concerns. So certainly everybody has the ability to respond as an individual, but if you are part of a larger professional organization, you can also share your concerns with them, as the organizations themselves will be submitting comments on behalf of their entire organization. So there's kind of, for many people, kind of two different avenues for their voices to be heard.
sorry, I'm just kind of scrolling some of the open ones. So Carmen, thank you for AA Home Care. She says represents many DME suppliers. So if you're a member of the AA Home Care, you can reach out for them for guidance reimbursement. Carmen, do you know if there's an email maybe you can put in the chat? I'm not over in the chat, so I don't know what's happening there.
I don't think they can see the chat.
Okay, that's right.
Yeah. If Carmen could submit something in the Q&A, and then I can acknowledge it, and that will make it viewable to everyone.
Okay. Sorry, I'm still just looking for things. Someone's asking Molly about if being able to choose specific manufacturers for the garments. I have no indication that actually, I mean, manufacturers, the individual manufacturing haven't ever come into any of this. I mean, it just talks about standard fit or custom made. So I see no reason why you wouldn't be able to select the type that you, the brand, manufacturer that you need. I mean, I know being on Medicare, for example, needing a walker or a wheelchair, there's several different types, and I could just pick, you know, the one I needed. Or even with my CPAP machine, there's two different or several different types, and it kind of depends on what my, you know, provider wanted me to have, what specifications. So,
I added Carmen's link to the original question. Thank you.
okay, thank you. We're coming up on the hour, so I see Carrie, I see your question regarding your capri as two garments, and I understand, like, you use a capri even though for it's one leg, so it's probably just like half a leg on the other. That should still just be seen as your. If obviously you need also the capri probably for the thigh up to your abdomen, and so that would be considered per body part. You can specifically, you know, speak to that in your comment. That we're hoping Medicare having these, and again, so this will be Medicare, and then other insurance should, you know, follow suit. But this is something you could describe in your public comment to make sure that this need is met. Because part of their coverage also stated anything that would be needed for the patient to wear it. So if you needed that type of compression to make sure all your areas were covered, or that you can wear it and keep it on, that's something that they're considering in the rule. And there's actually details that mention that specifically, like, for example, I have, bilateral in both legs. So technically I could technically someone with my type could wear a pantyhose, which would be one garment. I can't get a pantyhose on, especially at the level of compression I wear. So I wear knee highs and a capri to cover everything. And CMS in the rule details discusses how patients might need that type of individualized garments to fit their needs, to be able to put them on, and joints and different things like that. So that type of individualized needs are mentioned in the proposed language.
I'd like to comment a little bit more on that because you mentioned that, for you having bilateral, you really just need one, set of one stocking, to cover both legs in theory. But when the DME providers, do something maybe for one leg, for example, and you need a waist attachment, they're actually two distinct pieces. And then if you need something for your toes as well, that's another distinct piece. It's not considered one. And so I think it's really important that if you have that situation, much like me, you're going to want to make sure you try to comment on those things to demonstrate the complexity of what you're getting to help ensure that they have that feedback to cover all aspects of what you need, in terms of your compression.
Yeah, and like I said, like technically they could say there's a garment that would cover all my body parts, but if I can't get it on, it does me no good.
Mhm.
And just my size and things and the compression of a pantyhose to have both legs together at one time, to fit them on, because I usually have to put my leg up to the side to even put my knee highs on. So if one leg's up to the side, I'm not going to be able to get the other leg, the garments don't stretch enough for that.
Well, and then also each of those pieces have different compression levels, which is why
Yes.
they are different parts. Like the waist attachment might be 30 to 40, but the leg piece might be, 50 plus. And then the foot piece might be 30 to 40 again.
Yeah.
So I think that's why they're distinct. And that's why it's important that we call out these nuances to help ensure, that all of these, scenarios are covered.
And I think, this was one of the areas that was impressive, that they listened to us for them to include it. So I think we say, like, call out that it's great that they understand the individualized needs of patients. But by the way, here's a couple other needs that we want to make sure you are aware of.
Yeah.
And for them not to specifically mention it might not be exclusionary. It just might be they were just trying to put the main points in. So
I love how you call out, just acknowledging like the great things that they've done, because I will agree with you. When I first started to read it, I was like, this is really detailed. There's a lot of really good information in here, before getting a little bit nitpicky, right?
yeah, they had a very quick turnaround time to have this, drafted. And yeah, it's been 6 months, but this is coming. I'm sure this wasn't the only thing this group of employers had to do. So we're very appreciative that they accepted. They did some invitations for listening sessions, but then we also gave them names of places. So it was a very much a group effort to put together, all these organizations having listening sessions, and even communicating. I don't think it's anything to say, like, when we knew someone was having a listening session, we asked afterwards, hey, how'd it go? Was there any questions you need help answering? Anything like that. So we've very much been communicating amongst ourselves during this entire process also. I really want to reiterate that, I saw someone comment that they are, I think, a vendor, and they appreciate my take on reimbursement rates. I mean, I think we're all here for the patients, but as a patients, we realize if we want people to be here for us, we have to advocate to make sure they get what they need to provide those services for us.
Yeah.
So
There's a question in the chat that's open, and I'm afraid there's not an answer because that's like predicting you're going to have lymphedema. But the question is are there provisions for preventative compression? You know, having cancer, like, I don't know if there's protocols for folks to wear compression in advance of a lymphedema diagnosis.
So right now, you know, for the legislation, they'd have to have a diagnosis of lymphedema. However, diagnosis of lymphedema do come in stages, and there is, you know, multiple different types of staging. So you know, that's all I can say for that. So you would have to have a diagnosis, but that's just what the coverage is now. Is you need to have a diagnosis of lymphedema. So if you don't yet have a diagnosis, then likely, and you know, that wouldn't be covered. So, but with the different with the advancements in technology of diagnosis and staging, and especially if they are surveilling cancer patients where they're taking measurements beforehand and comparing them to afterwards, you might have that diagnosis at a very early stage, but that's at least what the law would be now, is you'd have to have a diagnosis. And it can be a primary or a secondary diagnosis of lymphedema.
This is Heather. I was going to add to that, in a much earlier draft of the bill, we actually did try to include language that said for the treatment and or prevention of lymphedema, and we're told that that had to be removed because Medicare doesn't typically cover prevention in that type of scenario. But as Sarah said, you know, there is stage 0 lymphedema, so you don't have to have swelling to be diagnosed with lymphedema. So hopefully that is a gray enough area that anyone who would need compression garments, even if it's just to prevent the swelling from even starting, would, you know, have that stage 0 diagnosis and be eligible for coverage.
That's awesome, because it can be so subtle, I think, for
Yes.
someone who is newly, you know, exposed to this condition, if you will.
I know we're at the hour. I think most of the things have been answered or addressed. Again, if you have questions that weren't answered, info@lymphedema treatmentact.org.